So, as we were saying, we were on geriatric considerations, and temperature is usually lower end of acceptable for geriatric patients. Temperature is considered within the normal range, may reflect a fever for an older adult, so we may see a lower temperature that indicates a fever for a geriatric patient. They also have a higher threshold for sweating at high temperatures, so this can lead to hyperthermia. They may not sweat even when they're very hot. Also, they have diminished sensations of cold, so they're at higher risk for hypothermia. They have abnormal vasoconstrictor responses and impaired shivering, so they may not respond to cold the way younger patients will. Once they have an elevated pulse rate, an older adult takes longer to return to a normal resting rate, so that's going to influence. Also, reduced heart rate with exercise due to decreased responsiveness of catecholamines. So they're going to have a reduced heart rate when they exercise as well, so they're going to have difficulty meeting their oxygen needs with exercise. There's changes in lung function in the elderly, so there's a respiratory rate are generally higher in older adults. So normal range for an older adult is 16 to 25 breaths a minute. So we consider that normal range. So they're going to be breathing faster, which of course means when they exercise, their respirations are going to go up as well. So that's going to be different in them. As far as blood pressure, because of loss of mass in the upper arm, especially in frail elderly, it may require special attention to select a smaller blood pressure cuff. Also, with elderly, because the skin is very fragile, they may have lost upper arm mass. You want to make sure that you are palpating for the systolic and not pumping that cuff up any higher than you absolutely have to, because you can damage the skin, you can bruise them. So you want to make sure that you're palpating for a systolic and not pumping that cuff up too high. So you need more frequent assessment under that cuff or rotation of blood pressure sites in order to not do damage and bruise them. As far as oxygen assessment, you may see clients with SpO2 less than 90%, particularly in patients that have COPD, emphysema, or other chronic respiratory problems. With the blood pressure changes and oxygen changes, we make sure that we instruct older adults to change positions slowly and wait after each change to avoid post-oral hypertension and prevent injuries. The pulse rate indicated on the oximeter is less than radial or apical pulse rates a lot of times. So we have to be aware of that. Make sure that you're taking an apical pulse and not just counting on that pulse oximetry pulse. We want to make sure we're observing for signs and symptoms of decreased oxygenation, such as cyanosis, restlessness, altered respiratory patterns, and tachycardia. So we want to be sure we're making sure we're looking for those. Reposition the probe and reevaluate the waveform. If we see a decrease in the SpO2, if it's unacceptable, make sure you're notifying your charge nurse or whoever it is that you're reporting to. That we may have to actually draw arterial blood gases. They may be ordered to look at what's going on with that. We want to make sure we minimize factors that decrease SpO2, such as lung secretions. If they're unable to get those out on their own, we may have to suction. If they have increased activity, altered neurologic status, or hyperthermia, any of those could affect SpO2. So we want to make sure we're doing what we can for those situations as well. Position the client in a position that maximizes ventilation effort. So we want to make sure that we're sitting them up. If they have a lot of lung secretions, remember that we want them elevated so that they can get maximum use of their lungs. Verify the appropriate oxygen delivery system and leader flow that's ordered. That's very important to make sure that they're getting the right amount of oxygen as well. Another thing with pulse oximetry, if the patient's hands are very cold, they have peripheral vascular disease, we may not be getting a good reading, so we might have to change the sensor site. We can use the earlobe probe, but you can't use a fingertip site, fingertip probe on the earlobe. You have to actually have the earlobe probe. So don't just take the one off their finger and tape it to their earlobe, because it's not going to work. You have to actually have the earlobe probe. But we can do that if the person's fingers are really cold, cyanotic. We're not going to get a good reading, so we might have to do that. Assess the apical and radial pulses along with other signs and symptoms that might indicate compromise of cardiac status or decreased peripheral blood flow to help with determining if that SpO2 is accurate. As far as geriatric concerns, identify acceptable sensor sites. May be very difficult for older adults because of peripheral vascular disease or vasoconstriction from cold or even anemia. So older adults may require more frequent assessment of skin under the sensor site as well. And a lot of times the tape on ones, they leave them on for a long time, and we can actually have tissue damage if we're not careful because of things like tissue fragility and also decreased elasticity. So we need to be taking those off and assessing the tissue underneath. Physical assessment, we need to be looking for things like headache, dizziness, pain, stiffness. Are they using tobacco or marijuana? And a lot of times we don't think about our patients using marijuana, but even some of our older patients could be using marijuana. Do they use alcohol or caffeine? And how much caffeine do they use in a day? Do they have anything like leg pain or cramping? That could indicate mineral deficiency or electrolyte deficiency. So that's important. Movement and position. How easily can they move and change position? Have they had any height decrease? We can see that in our elderly patients that have osteoporosis. We'll see it more, but we can see it in all elderly patients. Do they have any reduced sensation anywhere or weakness in any extremities? Remember that as far as smoking is a risk factor linked to incidence of lung cancer, heart disease, and chronic lung disease, and responsible for 87% of all lung cancers. It's also linked to bladder cancer and cancer of the pancreas. So smoking's been linked to a lot of different diseases. Caffeine can affect cardiac issues. Alcohol as a central nervous system depressant can also affect the liver. So there's a lot of those things we really need to know about. Height decrease could indicate osteoporosis. So a lot of these things we really want to know about. Occupation is another thing we want to assess. Occupation can create a risk for injury, potential for eye fatigue, for low noise exposure. They may have been exposed to particulate in their job, and that may be respiratory issues. Headache or dizziness could indicate problems such as high blood pressure or be from a resultant injury. We also want to know about things like allergies. Do they have any allergies to pollen, dust, airborne irritants, or any food, drug, or chemical allergies? They might have things like asthma. That could be an allergy. Additionally, caffeine and alcohol may cause tachycardia. So that's something we want to know about. We want to observe the client's movement and position. Position assumed by the client may reveal the nature and source of abdominal pain. Clients with appendicitis often lie on the side or the back with the knees flexed to reduce pain. So how the position that they get into can tell us a lot about what we're looking at when we're doing a physical assessment. Also, height decrease in women older than 50. It's a measurement that can be useful in screening for osteoporosis. A loss of height is frequently the first clinical sign of osteoporosis. And a loss of sensation or weakness in the extremities can indicate neurologic changes. So that's what I was talking about with headache. Can be a sign of stress, underlying problems such as hypertension. So we want to review their occupation. Smoking, lung cancer risk, heart disease, chronic lung disease. Responsible for 87% of all lung cancers. Allergies, pollen dust, airborne irritants, foods and drugs, chronic respiratory diseases. They might have wheezes, dyspnea, cyanosis, or diaphoresis. Alcohol can contribute to the risk of cardiovascular disease, also end-stage renal disease and liver disease. So for alcohol. Leg pain or cramping, if it's relieved or aggravated by walking or standing, or if during sleep, can help determine if it's vascular or musculoskeletal. Musculoskeletal pain is usually not relieved when exercise ends. This could indicate low potassium. It could also be connected to calcium. So there's a few things that it could be connected to. So that's important for us to know about. Movement and position. Lying still with the knees drawn up. Moving restlessly to find a comfortable position. All these things can indicate to us something about the patient, what's wrong with the patient. If they're lying on one side, sitting with their knees drawn up to the chest, it can reveal the nature and source of abdominal pain. So the movement and position are very important to us in our physical assessment. And then height decrease, as I said, can indicate osteoporosis. So subtract their current height from the recall of the maximum adult height in women over age 50 can tell us about osteoporosis. And reduced sensation. We want to test for signs of that to indicate neurologic changes. So when we find abnormal issues in our patient, if we find an abnormal assessment, so what to do about things like yellow nasal discharge, sneezing, and sinus pain? First of all, reposition them into semi-Fowlers or another comfortable position. So in the next section, we're going to talk about what to do about these abnormal findings.